welcome and thanks for coming along. I might get started. My name's Sue Scull. I'm the head of the Research Education Program here at CAHS, and I'm responsible for putting this seminar series together amongst other things. And if you haven't been to one of these before, the idea is that in an hour we do a really rapid fire overview of what's generally a really big topic, and we'll always point you to additional resources in the back of your handout. So you'll find all the PowerPoint slides, but you'll also find a whole lot of resources at the back, along with an evaluation form, which we'd be very pleased for you to fill in, because we're constantly trying to improve what we do from year to year. And if you ever miss one of our seminars, and we've got over 20, I think around 23, 24 this year, we do record them and we put them on our website every week, and there's always a complete set of the most up-to-date seminars there at all times. So if you know anyone who's missed out, that's always an option, and also you can link in from wherever you are outside the hospital at any time as well on the day. So because we record, I'll ask you to hold your questions till the end, because there are also people video linked in all around WA and sometimes beyond as well. So let's get started. And today I'm going to talk to you about really the fundamentals of getting a clear research question and then turning that into a very high quality protocol. And I'm going to start off by just talking a little bit about general conceptual approaches to research and the research pathway and what your responsibilities are as a researcher, and a bit about putting together a research team. So first up, we're going to have a revisit of why we're doing research in the first place, and then the approaches that we can take to get started. So hopefully we're all doing research because we want to fill a knowledge gap, and we want to obtain really high quality evidence to answer an important question that matters, and not just to you as an individual, but hopefully to a broader group of people as well. And ultimately we want to make a difference. So we want to be choosing something to conduct research on that is going to have an impact on policy and practice, and hopefully ultimately health, or our health processes. And if we want to be really simplistic and break down the major approaches, it would be into qualitative methods and quantitative methods. So I'm a paediatrician, but I also trained as a clinical epidemiologist, very much in the quantitative framework, where a lot of our research does happen, but they're actually equally important, and increasingly we use mixed methods, so a bit of both. And I think it's fair to say that qualitative research is very much exploratory and generally conducted on a small number of people and obtains very rich data. So it's often a really important place to start when you're doing research to determine whether you're on the right track. And often out of qualitative research come hypotheses that might underpin future quantitative studies, for example. So sometimes we see it starting in one area and moving into the other. So just by way of summary, we often, in qualitative research, collecting a whole lot of information in the forms of stories or words or talking to people, and then subjectively interpreting that information and trying to distill it down into themes or ideas. And it has very, very clear, strict methodology, just like quantitative research does, and there are many different approaches. We've actually got a separate seminar available on that, which will be repeated in November if you're interested in more in that. But I'm going to focus very much on quantitative research methods today, but much of it is hopefully our sound people will try and get whoever it is who's pressed the wrong button somewhere in WA to stop talking. On the other hand, quantitative research is very much about having a pre-designed exact idea of what you're going to measure and how you're going to measure it, and it generally uses numbers and statistics and very precise measurements, and we often classify and count. And because we're often classifying things, we're distilling things often into preordained categories, and that means we can next. So you have to have a really clear idea about what's right to be measuring in the first place when you're doing quantitative. And quantitative methods are a way of not only generating more hypotheses, but also testing a hypothesis and deciding whether something works or not, or what risk factors there might be, or what the long-term outcomes of a condition might be, as opposed to just getting a general idea of important components of a condition or a process. So qualitative is very labour intensive and time consuming, and quantitative is much more efficient and can have much larger numbers of people or cases in it, because everything is pre-decided and pre-categorised a lot of the time. So which one you choose depends very much on your question, and I'm going to talk more about choosing the right design for your question type as we get in further. So next I just want to briefly overview what the whole research pathway looks like, assuming that some of you may have done this before and some of you may not. But it's a big process, and I think a lot of people think about research as being the bit in the middle where it says data collection. And that actually is the really easy bit. I mean, it can be hard to recruit people and so on. But actually, most of the work goes into the preparation for that stage. So the more time you spend in all those things in the red circle, the more likely your actual data collection and analysis and interpretation of results will be much more simple, because you'll be well organised. So we're going to talk a lot today about the importance of a background review and clarifying a research question and getting clear objectives, and also methodology. So obviously I'm an epidemiologist. I think the methods are really important, and often when we read papers and things we sort of skip over that section, but actually it's really critical because it underpins how robust your data are going to be and whether you can answer your question at the end of the day. We're also going to talk about pilot testing and why that's important, and all of these things are happening at the same time. So at the start you'll also be getting your approvals, doing your budgeting, you might be even pre-planning your papers and your authorship. There's a whole lot of things that go on at that early stage. And then you go on and do your data collection, you clean your data, analyse it and report it, and then hopefully have some impact. So if we think about it as before, during and after data collection, before the data collection part I think is the really critical bit, and it doesn't necessarily happen in that order. Sometimes we have to jump around a bit as we're dotting our I's and crossing our T's and getting our approvals and so on. And you might come into a project where there are already data collected, or there's already a very clear question. But regardless of what point you come into a project, it's really important to make sure all these early steps have been done well, and for you to check that. So just because somebody says, you know, join the team, we're going to do this, it doesn't mean they've got it perfect. So it's really worth knowing what the processes are throughout all these different stages. And then obviously during data collection, it's not a static period. So we often need to go back and refine what we've already done. So we might have developed a data collection instrument at the start, a survey or whatever it is that you're collecting data with. And you might discover that the wording is clunky and can't be read out over the phone if it's a phone survey, or there are key outcome measurements that you've missed, and you might need to go back and redesign that data collection form and resubmit that to ethics, and you won't be able to use that new form until you've had that approved. So there are many processes at this point at the beginning of data collection that you might need to go back and tidy up, and that can take a little bit of time. And throughout the data collection period, you are also needing to do a lot of monitoring, and I'll talk more about that, but training and monitoring of staff, monitoring the way data are managed, entered and so on, and then all the standard operating procedures that go around different aspects of the study. It's also a time for ongoing dialogue, so we shouldn't be going off and collecting data on a whole lot of people without communicating back to them, your participants, or your key stakeholders, which might be funders, it might be other areas in the hospital or whichever site you work on. So that's a very important part at this point as well. And then you should be entering data as you go, because that's when you realise there's problems with your database. You might need to fix that, and you might need to do some data cleaning as you go so you don't discover massive problems at the end. So that's really important to factor in this middle part. And very occasionally you need to do interim data analyses. So for big randomised controlled trials, where you're doing an experiment, you absolutely have to be confident you're not doing more harm than good when people are involved. And frequently you're required to have interim analyses that will be looked at by an independent data safety monitoring board. So their job is to make sure that at some point through the study that everything's on track and there's more benefit than harm resulting from the intervention that you're trialling. And obviously much more simple studies, that would not be necessary. And then after you've collected the data, there's a whole lot of data cleaning that happens, which I'll talk a little bit to later. Obviously data analysis, and then the all-important critical interpretation of the findings. So this is the bit where you get to have fun and you really try and unpick what your data mean, and then communicate those findings and hopefully change policy or practice or whatever it is you're looking at, and think about what's going to happen next after your piece of research. And that might involve making recommendations about what new research projects might be logical to follow what you've done. It's a good time at the very beginning of this talk to also think about the research team. So obviously that depends on whether you're doing a student project with a supervisor or you're doing a massive 5-year NHMRC multi-million-dollar study as to how big your study team's going to be. But regardless of how small your team is, you should never work on a research project by yourself. It will always be better if you involve other people. And ideally, you would have had some input from a whole stack of people like on this list here. So larger studies will have multiple investigators. You might be the chief investigator. And if it's multi-site, perhaps you're even going to be the principal chief investigator across all of those sites. Then there are going to be a whole lot of key stakeholders like policymakers, funders and so on, and all importantly community members who are invaluable to the design, running, interpretation, every aspect of your project, which I'm also going to talk to in more detail. Essentially it's now a requirement and something that is a bit of a cultural shift in research and very much for the better. You might talk to cultural advisors depending on who you're working with in your projects. That can be really critical. And then there are people like me who are epidemiologists who can help with project design, or a data manager who could help with developing your database, helping with data cleaning, those sorts of issues. Project managers are essential for large projects who can oversee when the chief investigator can't be there all the time and they do all the day-to-day running. And then of course stats and communication. So overall it's really important to be inclusive and collaborative and do not work in isolation, and your project will be much better for it. So in terms of your responsibilities as a researcher, probably the key thing here are the words good clinical practice. So these are the national and international standards that guide research the world over, and are essentially a guideline for you to know what is expected in all aspects of research, including things like data management and security, but also right down to things like filing and version control of your different documents and so on. And the onus is on us as researchers to be up to date with GCP, good clinical practice training, and in some countries it's mandated by law. So if you're in the UK right now, you would have to undergo GCP training every 2 years and prove that you've got that active and up to date, or you wouldn't be able to do research. It's not quite at that level here, but increasingly you're not going to be able to submit to ethics unless you can say that you've had GCP training, and certainly your team won't get funding if you haven't all had GCP training. So there are a number of free online training programs to do that, and we have a short overview seminar that can tell you more about that. If you're a chief investigator, you'll be responsible for pretty much everything on this list. You can delegate, but it has to all be written down and signed off on. And monitoring is really important. So, as I said, big ones, randomised controlled trials, you might have an independent data safety monitoring board, but at the very least, you and your team or you and your supervisor should be meeting very regularly to troubleshoot and make sure everything's on track, time-wise, budget-wise, recruitment-wise, and so on. And then there are a whole lot of issues around staff. So very big projects will have staff coming in and out and changing and needing training and monitoring, and they'll need professional development and so on. And then just basics like following all the standard operating procedures that are in place and ensuring data quality and security. So we get ethics approval, but it doesn't stop there. Someone needs to be responsible for ensuring that the project continues as it was approved and not doing things that it wasn't approved to do. And things can drift over time if they're not being watched over. And we have to be prepared to keep our house in order so that if we are independently audited, like can happen with big sponsored trials, or even internally if there is a project monitor, which sometimes happens in research institutes or large health service providers, you might get audited internally to make sure that all your data are where they should be and securely locked up as they should be, and all procedures are being followed as they should be. And of course there's all the other things like sponsor requirements, scholarships, budget tracking and so on. I mentioned communication, and we'll come back to that again, but also throughout the project the investigators will be responsible for putting in regular reports to ethics, any amendments, as I mentioned before, and any adverse events that might occur with participants through the life of the project, and that's all covered in good clinical practice training. Okay, so when we start a research project, we need to be confident that we're picking something worthwhile. And then once we're confident of that, we need to be able to turn that into a clear question that can then underpin a protocol, which is what you would then use to attach to your ethics submission or your funding application. So how do we decide if something's worthwhile, and where do ideas come from in the first place? And I want to talk about why it's important to nurture ideas and then focus on the how do you decide whether it's worth pursuing. And obviously ideas do come from you in your workplace, or perhaps from your reading, and also from your supervisors. And I've deliberately chosen a kind of nutty professor look here, because just because your supervisor has a project doesn't mean it's necessarily a great one. It might be an old idea that's since been covered by someone else. It might be a whole bunch of data sitting in a drawer that was never designed to answer the question that they're interested in. So again, you really have to be finicky about what you take on and make sure that what you start with is robust. It's important to be nice or kind to ideas, because sometimes what starts off as a very basic idea or an idea that's not quite right can definitely evolve over time with discussion and all the things we're going to talk about into something really fantastic. And it's really worth putting all the effort into getting that question right at the start, because any of you who've done research already knows how much time and effort is involved. And it's not just your time and effort, it's all your participants and all the people that have funded it. And at the end of the day, it's your reputation and the reputation of where you work and the integrity for your participants. Okay. So let's talk a little bit more about why we would pursue particular ideas. And there are some key factors that are really worth thinking about. First up, research merit, then that should be researcher integrity, and then the underlying principles for ethics, which are justice, beneficence and respect. And I've put that photo there, which is a famous photo. How many of you have heard of the Tuskegee study in African Americans? Just very briefly, we all intend to conduct research in an ethical way, but sometimes things go wrong. This study was conducted from 1932 right up until 1972 on 600 African American men with syphilis, and penicillin became the curative treatment of choice in the 1940s. And this study that was intended to go for 6 months actually went for 40 years, and they never provided penicillin as an option, and these men remained untreated and got horrible complications, and some of them died, and it went on and on. Even after the 1960s, when some black medical students rotated through the program and raised the alarm, the program wasn't stopped until 1972. And finally, Bill Clinton apologised in 1997 to all the families that had been affected. So this is a horrible example of where people were actually not given the option of informed consent. They didn't really understand what the study was about, and it was never intended to go for 40 years without therapy and had terrible outcomes. So we need to follow ethical principles, and we need to have integrity as researchers. And I think everyone assumes that they're doing the right thing when they do research, but it's really important to truly be interested in finding new knowledge and also going about our business very honestly without a lack of bias. And that lack of bias and allowing scrutiny is important, not just with data collection, but also with the way we analyse, interpret and report our findings, which are sometimes skewed for whatever reason. And many of you will know this very famous case also of Andrew Wakefield, who in 1998 published a paper in The Lancet, a very prestigious journal, linking measles vaccine with autism, which was very rapidly disproved, but the ramifications have gone on for decades. In the 90s, there were massive outbreaks of tens of thousands of children with measles in the UK and in North America, and we all know measles has, for children, 1 in 4 hospitalisation rate, 1 or 2 per 1,000 die, and there were deaths, and there were a lot of morbidity associated with parents not vaccinating their children because they were frightened they were going to become autistic. And to this day, Andrew Wakefield, who was actually struck off as a doctor, is still pushing the same messages, still has friends in high places, went to the inaugural Trump ball in America with Elle Macpherson on his arm. So people get very invested in their own theories, but this was a clear case of medical fraud where there was undisclosed financial interests in the anti-vaccination lobby, etc., and data were altered for his own purposes. A horrible story. So moving right along, we're not going to be like that. We're going to follow ethical principles, and it's hard to summarise ethics in one slide, so I'm going to try and do that, but we do have 2 or 3 other seminars about ethics. But if I had to distill justice down to one thing, it would be the fair selection of participants based on your scientific objectives and not based on easy access to vulnerable or wealthy or privileged groups. And the idea behind that is that any risks or benefits afforded by the project will be equally distributed among everyone. Which brings me to beneficence. So that means that we should never undertake research unless we're confident that the benefits are going to outweigh the harms. And we have to think about harms beyond just this blood test might hurt a bit. We have to think about social implications, for example. So some projects are very onerous and require parents to bring their children in, say, every 2 weeks for 6 months and fill in long questionnaires and have tests and things, and that might affect their ability to do their job or look after their family at home. So we have to think about all the risks and weigh those things up. And then finally, respect really boils down to individuals having autonomy, having the right to choose, and that underpins the whole idea of informed consent and protecting the individual and having the right to say no. Okay, so moving right along, research merit is obviously a biggie. So we need to be confident that our project is going to answer something useful. And at the end of the day, I always say to people doing audits, which are really just simple surveys of our practice and where we can improve them, we always want to focus on the high risk, high volume or high cost issues. And we must choose things that are aligned with the research priorities, not just our own, but those of where we work and also the broader community. So just because you're very interested in something doesn't mean it's going to have a big impact at the end of the day. And we have to think about all the resources involved with research and what we put people through to get the answers that we're interested in. So there's got to be potential benefit, and we have to have thoroughly explored the area before we settle on it, because for starters, somebody might have already done what you're thinking of doing. And as well as that, we have to have very sound methodology. So for example, if we've got a terrible data collection tool and our answers are going to be difficult to interpret, or we haven't got enough participants because our recruitment processes were poor, then we might not end up with enough data or sufficiently robust data to be able to either answer our question at all or interpret the results at the end. And in worse still, someone might misapply our results. So it really is a big responsibility. And then, of course, the team has to have appropriate skills as well. And most of us don't have the luxury of thousands of helpers to do our research. So we do have to think about putting together a team with the necessary skill set, and we have to think about all the resources that are required and whether we can pull it off, and we might have to adjust our study design accordingly. So we've got to have enough people, enough expertise, enough resources, and we also have to pick the right study design. And that's one of the first things that happens when you submit your protocol is have you got a design that's actually going to answer the question. And clearly clinical relevance is so important, and I've touched on this already, but think beyond the personal or the local and try and go for things ultimately that are going to have a state or national or even international benefit, and think about what your research is going to add that hasn't been done before. And just because you love an idea doesn't necessarily make it fabulous, at least at the start anyway. So when you're reviewing around the topic you're interested in, yes, you do some reading and you talk to your colleagues, but also don't forget to talk to the wider community. And I'll talk more about community involvement and engagement in research, as opposed to just recruiting people into your study or showing it to your mum the night before and whether she thinks it's a good idea. And also definitely review at the same time the logistics, because you might end up with a much better question at the end of the day. And with literature review, be mindful that it's really good to be up to date with how to do a good literature research and know what sort of articles you need to look for. And we always aim for the highest quality, and I'll talk momentarily to that shortly. But also be aware that medical librarians or informationists are your best friends when it comes to setting up searches, using the right search terms, and helping you find the articles that are going to really unpick the area you're interested in. We don't actually teach literature review in this seminar series because most of the universities have fantastic resources and other sites also that are freely available, and it's really worth keeping yourself up to date on how to do that. So those basic critical appraisal of the literature skills are really, really important, because you need to work out whether there's already a definitive perfect study or whether it's worth embarking on something that's already been reported on before. So you need to be able to unpick whether the data are good quality and whether the results are applicable in your setting. And then I guess the other benefits of searching the literature are that you'll get lots of ideas about what data to collect in a related field. You might want to compare against other sites that have done something similar before, and you might want to align your design or your data collection with what other people have done. Now I'm going to talk to this idea of finding the highest or strongest level studies first, and I'll do that in a minute. Because it's really important that we don't waste our time reading studies that are very unlikely to impact on policy or practice. And just a quick word to say, when I first started doing research 100 years ago, we didn't have email or Skype, we did have phones. But usually you wrote to people by mail, and then 6 months later they'd say, I'm sorry, I don't work in that area anymore. But these days it's so easy to communicate with all the authors listed on papers, just so easy. Just do it, because the benefits can be really enormous. You can come across studies that haven't been published or are in process, abstracts from conferences, pull on their personal experience about what's important to collect or what they do differently next time. And they're often really helpful when it comes to unpicking data at the end and what they mean, and they might even want to collaborate with you, which will make your study even better. So community engagement I alluded to before, and we have a wonderful seminar by Anne McKenzie that you can look at already, or you can see her updated version in June. But But increasingly, it's basically essential for any funding applications, ethics applications, and if you do it, it's not to tick a box, it's because you're going to get a lot of benefits from talking to and involving community members in your research. And community members can be just interested citizens, but often they are people who come from a family with affected members in the clinical area that you're interested in, for example, which means that they've got a lot of personal experience to add to your research design. So they might say, well, that's important to you, but how's that going to benefit us? Or what we really think is important in, say, the asthma community are these particular issues for families, and they might have really important insights in how to recruit people, where to recruit them from, what sort of language to use, what are important data outcomes to collect. And they're really good at unpicking unexpected results as well. You might not be able to work out why something's happened, but community members might have very good insights. They're also wonderful at helping with just plain language writing, which we have to do for all our submissions, and wonderful advocates for getting results out and for talking to funding agencies, and increasingly community members actually are collaborators or co-investigators on projects these days, which is great. And we see people standing up alongside clinicians talking at conferences and giving their perspective on why that was important to do and what the results mean. So take it on board. There's lots of help available here if you're interested in community engagement, and no matter where you are, it's important to take on board. And in general, I would just like to stress that getting early input to your projects, not just from the biostatistician, which is also often left till too late, but across a range of people is really important, so that your design and data collection and your database and everything is all as slick as it can be before you start. We're very lucky here at CAHS. We have a research support office, and we have research support officers who are available at the end of an email. It's all in your handout. Any time to direct questions that you might have to people who can help. So getting that early is really good. And I've mentioned idea development forums as well. That's something we trialled here last year, where you had the opportunity to come along and describe what you're thinking of doing to a group of epidemiologists, statisticians, other researchers, and find out who else you could get involved or how you could refine your question, etc., etc. So it's about growing up that idea into something you could write down and be clear about. We're moving to a more one-on-one system because we think that'll be more efficient, and I really encourage you to speak to someone when you're starting out with a project idea as early as possible. Okay, so assuming you do have a great idea and you understand the good clinical practice and ethical aspects of research, defining your question is really important, and it's worth spending time on. And there's this really super easy evidence-based clinical practice tool called PICO, sometimes without the T, just making you include the 5 core elements of a question in your question and framing it accordingly. So the P just stands for population or participant, so who's in, who's out, what age group, whereabouts, consent, recruitment, all of that stuff can be fleshed out under P. The indicator is usually an intervention if you're doing a clinical trial, or it might be an exposure of interest. If there's a comparison group, that's where the C comes in, or it might be a baseline or a gold standard. O is for outcomes that you're interested in, and T is the time frame that you're going to do the study over. And I've just got a few little quick examples about how you would frame a question in this way, so you're not leaving out anything relevant. So here's a diagnostic type question in children with probable obstructive sleep apnea as the population does overnight oximetry testing as the exposure compared with a sleep study, that's our other baseline, diagnose obstructive sleep apnea equally well over the usual time period. And then of course, that's a starting point. You would then flesh that out. So what age children? Where are you going to recruit them from? What are the inclusion criteria? What are the exclusion criteria? How are you going to define obstructive sleep apnea? Based on what valid description would you define that? And then the same, you would have to define oximetry testing and what overnight means. You'd have to define what a sleep study is. And it would have to be using a valid instrument for wherever you're working, in whichever country you're in. And then what is equally well and what is a diagnosis of obstructive sleep apnea again. So all of these things are a starting point to flesh out further the study design. Here's a prediction type question. So these can be prediction questions looking forward or looking backward. So here's one where the population is in adolescence with a previous seizure. What risk factors predict seizure recurrence, no comparator, over a 1-year period? Or if it was a rare disorder, you might be looking, a common disorder, you could also look forward in time. And these are the most common questions we ask in clinical practice and the most important to answer because they are best answered by an experimental study design where you can look at cause and effect and how well things work. And these are randomised controlled trial type questions. So here's one in children with otitis media, ear infection. Does antibiotic therapy delayed by 48 hours as our indicator or intervention compared with usual therapy increased duration of pain or bulging of the eardrum as our outcomes of interest within 10 days of onset of symptoms? So again, all the key elements are there, and this is a starting point for fleshing out which children, how do you define otitis media? That's a big can of worms. What antibiotic therapy delayed by 48 hours, how are you going to define that? What's usual therapy? That could be quite tricky. And then how are you going to measure pain and how are you going to measure duration of pain and how are you going to measure bulging of the eardrum? Are you going to have mild, moderate, severe? Are you going to use a video otoscopy? What are you going to do? So all of that then gets you thinking about the next level of detail. And I mentioned before that choosing the right study design is critical, and once you've got your question, any statistician or epidemiologist would be able to help you say, well, here are the options for study designs, and now you have to weigh up your resources, feasibility, ethics, all the other factors that will help you choose the best design, which you then need to justify in your protocol. So check in with either an epi person or a stats person, and we've got lots of helpful places to go look if you want more information about that. And this is the old hierarchy of study design pyramid. And as we go up, we get more excited about how robust our results are going to be. And that's because we can more definitively tie cause to effect and adjust for other factors. And the reason why randomised controlled trials are right up the top is that by randomising, we can control for all the known and unknown potential confounding factors that can muddy the waters between cause and effect. And it's all about testing whether something works or not. Once you get down to cross-sectional studies and below, these are observational studies where everything's measured at once, so you can't say what's the chicken and what's the egg, because it's a snapshot in time. So those studies are considered weaker and more at risk of bias, whereas the studies at the top are considered stronger and more able to test hypotheses and look at cause and effect. And the reason why systematic reviews and meta-analyses are above randomised controlled trials is only if they are pooling data from well-conducted randomised controlled trials. If they're pooling data from a whole stack of cross-sectional studies, then they would only sit just above cross-sectional studies. But ideally, meta-analyses and systematic reviews are where you should be looking, or randomised controlled trials when you're looking in the literature for definitive studies. Okay, and just coming back to these very same questions. So if I was looking at a diagnostic type question, you could answer this with a cross-sectional snapshot in time, measuring everything at once type approach, or you could do a crossover design where each kid has one and then the other. For prediction questions, when you're looking at rare conditions and risk factors, looking backwards at risk factors, you would use a case control design. But if you're looking forward to look at what the outcome, what's the prognosis of a condition, then you would do a prospective cohort study if that was feasible. The higher you go up that pyramid, the more resources and intense the whole project design becomes, and culminating in a randomised controlled trial. So as I said, intervention questions are the most common types of questions we ask about in clinical practice. Does this work, or does this work better than something else? That's an experiment and best answered by a randomised controlled trial. Okay, so once we've got our question and our design clear, then we've got everything we need to write our protocol. And a good place to start is just very simply with some key headings, because it's really a roadmap that outlines everything you're going to do and how you're going to do it. And it's for you and your study team, but it's also the document that your sponsors or funders will want to see, and also when you apply to ethics you'll need to attach it so people can unpick everything you're going to do and make sure it's sound. But it's certainly a guiding document for your study team. As you can imagine, people coming in and out over time in big studies, there needs to be a roadmap to tell everybody what to do. And there are some key headings that you will generally find in a study protocol, but it can vary depending on where you might be applying or what the purpose of the protocol is for. It contains a whole lot of stuff. So where do you start? I always get people to sit down with their question and then try and turn that into a 2-page protocol by fleshing out that question as we talked about before. And as I said, get lots of advice and expect to make it an iterative process where you might sit down with your team, even if there's only 2 of you or 3 or 4 of you, and over several weeks work it up into something really clear. It's not something you can do in a day. And do think about how you can cut corners. So often you'll find that there might be a data collection form from another study that you could adapt to your needs, or hopefully if you work in a research institute or even in a large hospital where a lot of research is conducted, there'll be standardised approaches to managing data or filing data or version control or study monitoring or how to access community involvement. So if you can cut some corners there, it will save a lot of time. And I very facetiously written, it's got to be a joy to read. People don't want to read 50 pages of waffle full of scientific jargon and abbreviations. It's got to be succinct, objective, clearly and logically written in good English that, remember, a lot of people who read it will not be as expert as you are in the area that you're interested in. So when it comes to writing the background section, I think it's really important to get the order right and hit people straight up front with what the problem is that we're trying to solve. You shouldn't have to read 3 paragraphs to get there. That gets people very frustrated in terms of readability. So you tell them what the problem is, then you tell them what the evidence currently is and where the gaps are that you're going to fill, essentially. You're going to justify then, by filling that knowledge gap, what are you going to be able to achieve with that. And the justification part's really important because there does need to be a reason for doing this study, and whether it's changing clinical practice or improving health, it's got to be something valid and worthwhile. And usually at the end of the background section you would then clearly state your objectives or aim or hypothesis. Sometimes you're required to put both. And the key thing is that you shouldn't have 57 objectives. You should have 1 key objective and a couple of secondary ones, and then that's the order that you present your results in later on when you're writing up, and the conclusions and recommendations around them. And the most important thing is that it matches up with your question. And remember that the worse your methods are, the less clear, the sort of more woolly, then the more rubbish data you're going to get out at the end of the day. So do see a data manager or an epidemiologist. There are lots of people who can help you set up databases and make sure you're collecting what you need. And obviously this whole section is huge for methods, and all of these things are important. So we've talked about study design, we have talked about stakeholder involvement a bit. You need to justify where you're doing the research and why, and the same with the participants. So this is where you describe everything from eligibility to consent and recruitment processes, and it's also where you define key measures of exposure and outcome or equipment that you're going to use. People need to know that it's allowed in Australia to use this drug or allowed in Australia to use this equipment. and what valid tests you're going to use. I'll talk about a lot of these other things separately, and as I said, I think we've sort of covered community involvement and engagement in research and the benefits of that. But also remember that early on in your project you need to be getting site approval. So certainly here in the public health system, ethics and governance processes run side by side, and part of governance is getting approvals to do your research in different locations. So for example, in the hospital you might need to get approval from pharmacy and medical records and emergency department. And the person signing off is signing off to say, I understand the implications of this research coming through my department and any impact on our function or time or resources, and that they're okay with that. So that's really critical. And in terms of coming up with an analysis plan for a protocol, a lot of people say, oh, I really don't know where to start. So start with writing the titles of the papers that you're planning to publish at the end, and then write your abstract, because you already know the problem and the justification and the planned impact and the knowledge gap. And then you know your study design. So then it's about picking out the variables that you want to measure in order to answer those questions, and then making sure you're collecting that data in a way that's going to be helpful so that you can answer the research question. And you shouldn't be collecting a whole stack of other data just in case. It's not a big fishing expedition. That will waste lots of time and resources, not just yours but your participants as well. And you can even outline your tables and graphs that you might like to do, and that will help you think, oh, well, if I want to do that graph, then I'm going to need to break this outcome variable down into these different categories, or I want to collect it as a continuous variable and chop it up later in different ways. So you certainly need to go and see a statistician before you start if you're not confident in doing your own sample size calculation. And this is a calculation that enables you to have the right number of people who complete the study, not the ones you recruit, but the ones who you recruit and complete, so that you've got enough data to be able to answer with confidence the question you want to answer the most. And later on you'll need to explain whether you reach that sample size or not. And usually when we're doing our analysis plan, we start off simply describing the cases or the people in the project, and how many were recruited and then consented and then dropped out or didn't complete for whatever reason, and then who completed. And then you describe them, their comorbidities, their age, their gender, that kind of thing. And then you start doing simple univariate analyses to look at how exposures and outcomes are affected by each other, and then the clever multivariate analyses using stats packages where you can adjust for a whole lot of other factors. And I should say that a lot of this stuff is really quite straightforward these days. Even the sample size calculators, they're all online, and if you know the 3 or 4 things that you need, it will even spit out what you need to write to put into your protocol for you, and the statisticians can quickly steer you to those sites. And then obviously the next part is you're going to have your data collection instrument attached to your protocol so people can see what you're going to be collecting, and you need again to be prepared to develop that over time and even potentially fix it up once you've started data collection and then go back again. And if you've never created a data collection instrument before, I really recommend you either read our clinical audit handbook or come along to our survey seminar or look at it online, and the data management one as well, because there's lots of really great ways to save time and have really high quality data by putting in things like compulsory fields and only certain outcomes allowed, and having only ranges of values allowed. And using proper data entry packages, and please not Excel, don't get me started, and having unique identifiers that are not the hospital record number or someone's date of birth or something else that makes them readily identifiable. So there's a lot of things around security and ease of entering data and keeping data as clean as possible that will save you a lot of time. And I think we've talked about most of these things already, but in a protocol they would expect to read something about how you're going to keep your data safe and store it, and it's also relevant to your budget because you have to keep some research data forever and there has to be a budget around that, and you need to be able to tell them how you're going to de-identify data and back it up and who's going to have access, and all of those things are really important. That comes through GCP training so that you know exactly what you should be doing, and especially things like version control, making sure everyone's using the most recently approved version of different forms from ethics. So there's a lot of people that can help you with that stuff if you're unsure. And then, again, relevant to your timelines and your budget, you must have time allowed and budget allowed for data cleaning, which I always tell people can take as long as the data collection itself, depending on what type of project it is, but you've got to check every single variable before you start analysis, and that takes some expertise and time, and you might even have to pay someone else to do it, but you have to do logic checks, you have to look for crazy values, you have to look for dates in logical orders, and make sure all the unique fields are unique, and make sure all the compulsory fields have been filled in, and etc, etc. So there are a lot of good data entry packages that make all of that happen very smoothly, and certainly in the health system in WA we're moving very rapidly towards REDCap for everything because it's a fantastic free on-site program that will keep your data safe and lovely and clean. And Excel, I just really need to say, I know everybody uses it because it's on your computer already, but it's not a data entry package. You can easily scramble all your data just by hitting the column button by mistake and changing one column and not bringing everything with you, and you'd never even know, and you wouldn't be able to fix it. And you can't put all those checks and balances in up front that stop you putting in silly things. So these are specifically designed for data entry. Multiple people can enter at once in different places. Only certain people can have access in different places. So lots of benefits to using a proper data entry package. I don't think I'll talk any more about study monitoring, except that, again, you may need to include it in your protocol. And it'll be important to have a document somewhere that explains who has responsibility for these different aspects, particularly for randomised controlled trials. I've mentioned piloting. It's the step that everyone wants to skip because it takes time, but it's the best ever mistake detecting device, and really it just helps you with ethics and funding, because if people think that method of recruitment's never going to work, or they're never going to reach that sample size, or whatever, if you've already shown you can do it and that it's run smoothly and you've already ironed out all those problems, then it's going to sail through. It's also a fantastic way to get some real data to underpin a real sample size calculation that's likely to be about right, and it will certainly help you get funding if you've done piloting. And sometimes a good place to start is to apply for a little seeding grant to do a pilot project and then do your big application for a big formal study later on. I've mentioned timelines and how important they are, and there's just so many things to think of. It's a really good idea in a protocol to include a little flow diagram, and there's lots of software you can use now, but even if you just use the table with the months and who's doing what down the side at what time, that's very helpful, and it's also a reference for your team to go back to, or you as the chief investigator perhaps, to make sure everything's on track. But there is a lot to think about, and that's not an exhaustive list there, but you need to allow for the pointy end. Once you've done the data collection and analysis and written your report, that's not where it finishes. There's still more to be done, getting things out to your participants and all the stakeholders that need to know about your results. So do be realistic, because that's the first thing people will pick up on when you're submitting for funding or ethics, that you're not being realistic or you don't have enough resources. Which brings me to the budget. So essentially it's an ethical issue if you don't have enough resources to finish the project after all the work that you've done. And getting it right is quite hard sometimes because you don't want to overestimate and you don't want to underestimate. But I've actually got 2 whole slides on things to think about. Again, that's not an exhaustive list, but it gives you some ideas. And there are templates now within the research governance system, the online RGS, where we put in applications these days for ethics and governance, that can guide you through a budget. And probably the critical thing is that firstly, you have to put in everything that's a cost above usual activities, and you have to include in-kind costs as well. So everything has a cost, and it's really important to understand the true cost of research. And even if your time is unpaid, you do normally have an hourly rate, and you can put that in the in-kind section so that people can see that the project is going to be achieved and what the actual cost of it is. I've put a big asterisk next to staff because the things that are pitfalls that people frequently forget are things like annual increments, professional development. People go on leave for long projects, people actually leave the project, and you've got to then re-advertise, retrain, hire. All of those things take a lot of effort. Yeah, and a very, very long list of things to think about. I really recommend that you put in a budget for larger projects, money to assist with getting statistical input, data management input. There are other things for, say, clinical trials like insurance costs and so on that need to be considered. So they all take time and they all use resources. So just really dot your I's and cross your T's when it comes to the budget, and show it to your business manager or whoever else can help, because they'll also have ideas, as will other researchers who've done similar research when you're trying to guess how much laboratory tests are going to cost or some other aspect that you've not had to think of before. And finally, the communication plan is just so important. So for me, this is part of the pointy end that is critical, because if we don't get our results out there beyond a publication in a peer-reviewed journal, we haven't done our job. So we have responsibility to our participants and all of our stakeholders, and especially the wider community. And we have some fantastic talks, a new one this year on even use of social media in everything from recruiting to getting your results out, and how you can do that really effectively. So very important aspect of research, and it doesn't stop at your peer-reviewed paper. I guess the other key thing is what I've written there. If you don't publish or get your results out, someone else is going to waste a whole stack of time and resources doing exactly the same study you just did. So there's lots of reasons why it's good to get things out there, and especially conferences early on, when you've got the early data, you can get some great feedback on further interpretation or other things you could look at. And as I said, it goes right through the project. And there's more than one way of doing things. So think beyond written and even oral, and remember social media, television, radio. There's lots of different ways to get your data out there. And when you get to the end of the day and you've done your critical thinking, you don't always find what you expected to find, but it's really important that you get the results out and into policy and practice. And very important that you budget for that. So a lot of people think, well, I've got to race on to the next application or go back to my normal job. But even if you can't do it, make sure you've handed it over to someone who can, or forwarded the data up to the next level so that someone else can carry it forward. So, in the nick of time, this is a very general overview of research, but I think it's really important to be kind to ideas, no matter who's got them, and try and turn them into something really worthwhile. Remember, never work on your own, and put together a good team with the expertise that can pull it off, and make sure you've got the right research design for your question. When it comes to writing your protocol, it's got to be easy to read, but it's got to have all the necessary detail in there, and take time over that. And the more effort you put in at that front end of that research process and getting all your processes and thinking clear, then the easier the rest of it is. You should sail through it. There's a lot of help available, particularly on this campus, so make sure you use it. And don't forget to pilot. It's a step you leave out at your peril. So thank you, and yes, go forth and enjoy your research, and don't forget to come and ask for help. And we've got some other seminars coming up shortly. And don't forget to fill in your evaluation form. Before I go, does anyone have any comments or questions related to the seminar today? We have a microphone. Or if that was all really clear, or if you're feeling shy and you would like to talk to me afterwards, I'll be here for a few minutes and we'd be very happy to talk to you. Are there any questions? Comments? Okay, well, thank you all very much for coming. I hope you found at least something useful in amongst all of that rapid whirlwind tour, and I hope to see you again here at the Research Skills Seminars. Thank you. Yeah, sure. Yes, that's what these are for. Yeah, sure. Well, that's a good way to do it. Fantastic. Yes, that's what cancer is. Absolutely, it does. It's using data and do you work? Yes, definitely. Where do you work? Oh, perfect. So anyone who works here